All right, it's Chad back at you here for Chapter 4, Unit 2. We'll come back to Chapter 3. It just fits kind of after the boring sections. It fits more when we get into the actual EMS stuff. Chapter 4 is also a very dry chapter. It is a very important chapter if you want to keep an EMS license for any period of time. And if you're a lawyer, this is right up your alley. But we're going to cover medical, legal, and ethical issues. Very pertinent in the world of EMS, and these are things that you will deal with every time that you have a patient. Three basic topics here: scope of practice, what you can do, patient consent, and refusal. So talking about consent, how patients refuse, what everything is that you need to do, and then just some other legal issues that pertain to the world of EMS. Okay, jumping into scope of practice here. It's regulations and ethical considerations that define the scope or extent and limits of an EMT's job. That includes skills, medical interventions, and those are kind of defined and set by state legislation and regional rules and guidelines. So this basically is telling you what you can do, when you can do it, when you need to call for assistance. Basically everything that we talked about in that first chapter with the medical director and the protocols, everything within that scope of practice fits into those protocols. So basically if it's in your protocol, it's in your scope of practice, and then it's something that you can do to help benefit the patient. And then as we compare that to standard of care, it's basically the care that would be expected from an EMT with similar training when caring for a patient in a similar situation. So when we talked about the NREMT and kind of those national standards, that's more or less where we're getting the standard of care from. Basically saying that if you're an EMT basic in Illinois, you can do the same things as an EMT basic in Massachusetts within your region and within your protocols that your medical director sets up for you. Medical director can deviate somewhat from what those national standards are. They might give you a little bit of flexibility to do a few extra things with some special training, but they also may not feel comfortable with certain things that you have learned and say, yeah, these aren't going to fall within your protocol, so you're not going to be able to do them. So as you just compare those two, scope of practice is basically what you can do. And it's important as a student to understand scope of practice because when you go to your clinical sites and things like that, it's on you to work within your scope. So basically, a nurse may not know exactly what you can and can't do, but you should know what you can and can't do. And therefore, you work within that scope of practice, which is basically everything you're going to learn in this book. And then standard of care is how you should do it. So what you can do versus how you should do it. All right, now we're going to move on to consent, and there's a handful of slides here talking about the basics of consent. Most of it is very common sense, as you're going to see right here on this initial slide. But basically, it's consent is the way that you get permission to assess, treat, and transport your patient. So express consent, they express it to you. It must be informed to you. They must tell you, yes, you can do that. If they're conscious, alert, and oriented, they have every right to refuse. So before you do any interventions, before you put your hands on them, before you do anything, you have to get this expressed consent from them that, yeah, it's okay for you to take care of them. And then you compare that to implied consent, which is you're assuming they want you to take care of them. So this is going to be that unconscious patient or severely altered mental status patient. They don't really have the capability of telling you they don't want you to take care of them. So unless there's other factors as far as do not resuscitate or some other things that family may have information to, your assumption is that they want life-saving intervention. You're going to do what you can to help them. So consent as far as children and even mentally incompetent adults go, and it's pretty straightforward, pretty common sense to understand when they're mentally incompetent adults. And, when in question, whoever their guardian is should have some sort of paperwork stating that they're the ones that make the medical decisions for that incompetent adult. But children is anybody under the age of 18, with the exception of a couple instances like where they're emancipated or where they have their own child. I think there's a slide on that in a little bit. But otherwise, if they're under the age of 18, they're not legally permitted to provide consent or refusal for treatment on their own. So you go out to a car accident with two 16-year-olds, unless you have a parent there to sign for them, even if there is zero injury and there is zero injury, and 100 out of 100 adults you would let refuse because they're 16, because there's no parent there that can sign for them, you're going to have to transport them for further care unless you get a hold of the parents, and then you have to kind of work within your protocols as if you can get a refusal over the phone or if you have to have them there in person. Some of that just depends on the protocol, but you have to have a parent provide that consent or refusal for the treatment. A couple of exceptions in loco parentis is basically in place of the parents. So you may have an incident where the child's at daycare or the child is at school. Then those providers can act on behalf of the child and say, hey, this kid's sick, they need to go to the hospital. And then when the parents get contacted, basically they'll come to the hospital and then they'll provide further consent at the hospital. But from an EMS standpoint, you're looking at it as, I have somebody here that can make the decision for the child. Sometimes that person will have a note, sometimes they won't. But basically you're the one that's going to end up having to transport them, regardless if there's parents are contacted or not. Same thing goes for schools. It's a little bit different. Basically, when the child's at school, the school is the caretaker of the child. So buses driving kids home from school, they get into a car accident. The school can come out and truly have the legal authority to say, hey, these kids are fine, they don't need to go to the hospital, or say, yeah, these kids do need to go to the hospital. That's one exception. And then, like I talked about just a few seconds ago, the emancipated minors. So if they've joined the military, if they have their own child, if they've gone through the legal process, they should have paperwork that supports that. But then that person basically becomes an adult as far as status goes, and they can, refuse care. They can consent for care on their own without parental consent. So continuing with the children here, and I touched on I really touched on all of this last slide. But just a couple more exceptions, kind of depending on your local law, your local protocols. But that life-threatening injury, illness, it's going to fall back to the beginning of this chapter, and it's going to fall back to that implied consent. So if there's life-threatening illness or injury, you're just going to assume that they want care taken for them. And then, again, following on that, emancipated minors, if they have a child, if they're serving in the armed forces, then they make their own decisions. They no longer have mom or dad or guardian, whatever the case may be, making decisions for them. And the last little topic here under the consent agenda is involuntary transportation. And this is kind of a difficult gray area for EMS. But basically, this patient's going to be considered a threat to themselves or others. Now, people think that when somebody is intoxicated that they don't have the choice, that they have to go, and that is absolutely not the case. Just because you're intoxicated doesn't mean you're not capable of making your own decisions. This really involves more that suicidal patient, that homicidal patient, and they need to go to a mental health facility, either for psychiatric care or because they overdosed and need medical care. Whatever the case may be, this is that type of person that is going to go. Sometimes there's a court order. More times than not, it's going to come from a police officer or perhaps, depending where you're at, a mental health professional. If you're in a bigger city where there's a psychiatrist office, you might get called to that office to take them over for inpatient care. What we deal with a lot is from the police officer. So police get there, they secure the scene, because remember, you're number one. You have to take care of yourself first. And then the police may say, yeah, this guy has to go. It still becomes kind of a gray area, because if the police don't go and sign saying that they're the ones that are making them go, then it's going to fall back on you. So you put yourself, if you don't follow your protocols, if you don't follow the standard of care, you can put yourself at a great liability for really anything from kidnapping the patient to battery on the patient, if you don't go through all of the steps. So if the police officer is going to say they have to go, then they need to sign off on them, or the patient needs to agree with the police officer, and then they're really more going willingly than involuntary. If the patient is restrained, that's a whole different liability for you as an EMS person. So there's a couple things you have to look at here. One is, did the police department restrain the patient, or are you restraining the patient? If you're the one that's going to restrain the patient, we talked about where you have to call and get medical control authorization to use the restraints on the patient. Usually it's not going to be questioned in these type of situations, but you do need to get that kind of go-ahead from medical control. If the police department have them handcuffed, they can't just throw them in the back of your ambulance and have you transport them, because you have to be able to get those handcuffs off if that patient goes unresponsive, whatever the case may be in the back of the ambulance. So if the police officer is persistent that, hey, this patient needs to remain in cuffs, then that police officer needs to ride with you in the ambulance to make sure that nothing goes south while you're taking care of the patient. When in doubt, call medical control. Always get authorization from medical control. Whenever you have questions, utilize medical control, because then you're kind of passing the buck down the hill. So instead of a lot of that liability falling on you, by utilizing medical control, you've kind of CYA yourself, and basically now you've passed the buck on to medical control. If something goes south, it's going to be, hey, well, this is what I was told to do. This is the direction I was given. And, then that outcome doesn't necessarily fall back completely on you. But involuntary transportation can be very sketchy. Just make sure to cover your own butt. All right, moving on to refusals. And there are a number of slides here talking about patient refusals, even though when you think about a patient refusing care, you probably think simple. There's nothing wrong with them. Why is it so complex? But again, you fall at a great risk of liability with patients refusing care. Just take the example of, hey, this patient refuses care, you give them a quick check over, and you leave, but you didn't do everything the way you should have by the standard of care, and then an hour later some family member finds them dead. Now that refusal of care, because you didn't go through the steps, could come back on you as a liability, potentially. So there are a number of things that you have to think about when it comes to refusal of cares. They must be legally able to consent. So it's got to be that consenting adult, or a consenting adult for a child, or the incompetent adult patient would have to have somebody refuse for them. The patient must be awake and oriented. So it doesn't matter the situation, even if they're an incompetent adult. If they're still breathing, you can't just take the refusal from a third party unless you're going to go through medical control and get complete approval through them. That would be the only instance when, if it's a bedridden person and that's their normal mental status, then maybe a refusal is appropriate. But go through the steps, pass that buck on to medical control. The patient must be fully informed. So you must give them all of the information at hand. And honestly, basically, you can close that refusal by saying, look, it's in your best interest to go to the hospital, but you have the right to refuse. Just understand these are some of the potential consequences, and it could be up to and including death. And if they still choose that's completely up to them, as long as they're competent and they're legally able to refuse. If a person wants to die at home, hey, that's their right. And when they go unresponsive, family can call you back, and then you can take care of them. But it's entirely possible that they know they're dying, they don't want to go, and you know they're dying and that they need to go, but it's completely up to them. And then the patient must sign a release form. So every ambulance service is going to have their own refusal form. You need to make sure that they sign it, and then it's going to talk about witnesses and stuff, I believe, coming up, but you got to have witnesses sign it as well, so that it's not just a he said, she said type of situation if something were to come to light from it. You can follow everything to a T. There's still a chance it can go south and you can be held liable. Refusals are one of the biggest areas of lawsuits in the world of EMS. So, one, cover your own butt. When in question, utilize medical control. And two, document. You need to write an outstanding chart. I can tell you for myself that my charts, when it's a refusal, are longer than any time that I transport a patient, because I am covering every single basis possible in that paperwork, so that if something comes out on it, that's the legal document that protects you. So we've talked a little bit about the basics of the refusal. Now we're going to talk a little bit about your role in the refusal. Obviously, there are going to be times where you feel a refusal is completely appropriate, and then it's just a matter of going through the process by what everything you're learning here says, to make sure that you kind of cover your own butt. There will be times that you have patients that you take care of that want to refuse, that you truly believe need to go to the hospital. So what do you do in those situations? How can you kind of turn the tide, per se, to get them to go to the hospital? I will tell you, in my experience, the vast majority, probably 95% or better, that want to refuse initially, when I believe that they need to go to the hospital, it's really not that hard to talk them into going. So basically, spend time talking to the patient. Find out their rationale why they don't want to go. A lot of the times it's a financial burden. Sometimes they're afraid of what the outcome might be, that they could be in the hospital for a while. Sometimes people have had bad experiences at the hospital. Maybe it's a 80-year-old man who had his wife die at that hospital not that long ago. They don't want to go back because maybe they feel they could have the same outcome, or they feel, in a sense, hostile to the hospital because they couldn't save their significant other. So just spend some time talking to them. If you can understand why they want to refuse, then a lot of times you can take that information and turn it into convincing them to go get checked out. Reassure them in any way possible without lying. Never lie to your patient, but you can be reassuring to them. Inform the patient of the consequences if they don't go to the hospital. Sometimes you will know somebody's really sick, but they won't know that they're really sick, or they might just think it's really not as bad as what it really is. So sometimes just by explaining the consequences of not going to the hospital, that's enough to more or less scare them into going to the hospital. So use any tool that you can right there. Spend time speaking to them, listen to them, and inform them of the consequences. Those are like the first three very basic steps that you can take in getting that patient to go to the hospital. And if those items fail, then you still have some other options. You can consult medical direction. I've had the doctor talk to patients on the phone to try to convince them. Not very often. Usually you can convince them on your own, but it is another resource that you have. You can also if there's family there, have the family try to talk to them, and then make sure it's okay to call a family member. Don't just go do it on your own, but you still need to get permission to do that. But get somebody there. Try not to leave the patient alone if they refuse, even though legally you can. It's going to be best for you if you leave them in the care of somebody, so that way if something does happen, there's somebody there with them, and then it kind of covers you a little bit from a liability standpoint as well. From there, depending on the situation, you can utilize law enforcement. We talked a little bit about that involuntary transport. So if you feel that this is a patient that's a threat to themselves or a threat to others, and you don't have law enforcement at hand, or maybe they didn't portray that picture to the law enforcement, then what you need to do is talk to law enforcement separately. Say, hey, this is what's going on. Can you come back in, talk to the patient some more? I think this patient needs to go maybe involuntarily. And then you work hand in hand with law enforcement to kind of make a plan moving forward. Doesn't mean that you're necessarily going to be able to transport them, because they may change their tune again, and sometimes you're just stuck. But sometimes law enforcement can be used as a good tool, and sometimes law enforcement more or less will scare the patient into going, especially if it's in a situation where they could potentially be arrested. I hate to say it, but a lot of times the police will throw out there, hey, you either go to the hospital or you go to jail. And 99 times out of 100, the patient's going to say, take me to the hospital. So all of that fails. Patient still wants to refuse. You need to have them sign. They have to sign the refusal. If they refuse to sign the refusal, make sure that you have ample witnesses there that sign off on the refusal form with you, so that you can cover your own butt. I keep saying cover your own butt, but refusals, it always falls back to cover your own butt. But get them to sign it. Make sure that you explain all of the consequences up to and including death. And then you have to make sure that you document everything to a T in your patient care report. That way, if something happens down the road, they end up in court with you, that's your protection. You have the witnesses, you have the documentation, and that portrays the picture. You might be going to court months, if not years and years down the road. So for you to just remember things is difficult. That's why it's so important to document it so well. So we're at a think about it here. So just what are the risks of beginning treatment or transport without getting consent from the patient? What could be a bad outcome for you? Like if you begin care without getting consent, what could potentially happen to you? If you take somebody to the hospital that didn't want to go, what could potentially happen to you? What do you do if the patient refuses to sign the refusal of care form? And we just kind of talked about that. And I'm going to give you, it's a very extreme example of a refusal that I had several years ago, just to put it in perspective of using the resources. So we got called to a local establishment, CPR is in progress. We get there, patient is conscious, alert, completely oriented, everything, answering all questions appropriately. I'm not 100% sure if maybe people overreacted and started CPR when it didn't need to be. It could have been just that the patient passed out, and it could have been that the patient truly went into cardiac arrest and they got him back. Patient's conscious, alert, and oriented. I'm trying to talk them into going. Patient adamantly refuses. I have the police come talk to him, try to get him to go. Patient adamantly refuses. I call medical control, who directs me to do everything in my power to convince the person to go, but that I can't force them to go. So the physician on the other end of the line actually talked to the patient for probably between 5 and 10 minutes on the phone. Patient still adamantly refused to go. So then ultimately I talked to medical control again. Medical control said, you've done everything within your power. Patient has every ability to refuse. So here's this guy who just had CPR done on him and now is signing a refusal. It's an extremely crazy scenario, but it's a real life scenario. I had it happen right here in little small town Erie. So it's possible. Patient refused, ended up calling us back about an hour later, and he was having a heart attack. So luckily, he did change his mind down the road, and that's one thing with the refusal is, make sure to always end it with follow up with your medical provider, go to a hospital if anything changes, or immediately call us back if anything changes. Make sure that they understand that just because they refuse now doesn't mean 10 minutes from now they can't change their mind. And a little bit of incidental redundancy here, but back in the, thinking about it, when you subject that patient to unwanted care and transport, it could be viewed in the court as an assault or battery. Even as simple as you check their blood sugar without getting their permission, you poked them with a needle, technically you battered the patient if you didn't have their consent. So it can be very touchy when it comes to consent, when it comes to refusing. So always make sure you have consent, always make sure to cover your butt. Kind of very repetitively, witnesses, and not just your partner. Have law enforcement, have family, have an outside person sign that refusal form so it doesn't come back on it's the patient versus the EMS crew. You always want to have that third party involved whenever possible, so that there's more than just two perspectives. And then, like we just talked about, if they change their mind, they can call you back. Make sure that they fully understand that. And just kind of the, final speaking points here on refusal of care, but have a friend or relative remain with the patient whenever possible. Don't leave them there alone. If something changes, make sure that they have the ability to get help when needed. It's not always going to be that case, and ultimately a patient has the right to refuse whether there's somebody there with them or not. But best practice is that you're going to have somebody there with them. It can be a neighbor, it could be really anybody that the patient's comfortable with, just to make sure that everything's progressing the right direction. And then document everything as thoroughly as possible. Like I said, your patient refusal chart should be longer than a significantly ill patient because you need to cover your butt. Refusals are touchy, but follow the standards that you learn, follow your protocols, use medical direction, and you shouldn't have any issues down the road. Okay, onward to another, I don't want to say common, but you will see it regularly through your EMS career of what to do in the situation where a patient is in cardiac arrest and there's a DNR or other form of paperwork that kind of gives directions. So a DNR is a legal document expressing the patient's wishes if they're unable to speak for themselves. A lot of times this is an older person that they don't want to sustain lifelong treatment. They don't want to be put on a ventilator forever. Or it's a terminally ill patient that death is imminent. So they get this legal document that says, hey, if I stop breathing, don't do anything for me. It can be tough because they could still have a heartbeat and they've stopped breathing, but if they have a DNR, that's their wish. So you have to work with the family. You need to have the document in hand. You can't just take somebody's word for it. Usually in these situations, the document's readily available to that person. Now there's also a couple things that are slightly different from a formal do not resuscitate, and they're advanced directives or physician order for life-sustaining treatment. And those documents, a universal DNR says if they're not breathing, if they don't have a heartbeat, you're doing nothing. An advanced directive or POLST, they may have specific criteria that say you can do this, this, and this, but I don't want this. So a common one you see is people don't want to be on a ventilator. So you can perform, life sustaining treatment, but if they're going to be on a ventilator for any prolonged time, they don't want that. And then ultimately that's going to be past your care. It's going to be after you transfer care at the hospital. But there may be some specific directives in there that say what you can and can't do. Again, when in question, call medical control. Tell them what you have. Tell them what the document says. See what they have to say. Let them give you direction if you're not 100% sure on what you should or should not do. All right, now we're going to talk a little bit about negligence. A few slides here, and negligence is going to be the biggest reason for lawsuits against EMS personnel. And in the grand scheme, if you look at the number of times EMS are requested on a daily basis throughout the whole country compared to the number of lawsuits that would be brought from those calls, it's really a minuscule amount. But if you look at lawsuits towards EMS, negligence is going to be the top of the list. And basically, it's going to be something that should have been done that was not done or done incorrectly. So you had a duty to act, and it's going to talk about duty to act a little bit later, because just because you have an EMS license doesn't mean that you always have a duty to act. There are times and situations when you do, and then there are times and situations when you don't. And then there's the breach of duty, which means you failed in providing that standard of care that was expected, or you failed to act. So you have been taught all of this material through this entire EMT class, and you knew what you were supposed to do to provide care for the patient, but you didn't provide that care for whatever reason, whether you froze, whether you didn't think it was necessary, whether you were freelancing and doing your own thing. It doesn't matter. It's a breach of duty at that point. And that is going to be when you can be held negligent, in essence. So in negligence, what must be proven? It's that proximate causation. So the patient suffered harm. It can be physical. It can be emotional. But it's because of the EMT's action or inaction. And your book does have a good example. And I joke every time I pull the card out of the patient that, hey, I haven't dropped anybody today. Truly, in 20 years, I've never dropped anybody. But, the book's example is you dropped that patient pulling them out of the back of the ambulance. It is an action that you did that may have caused injury, may have caused psychological injury, but that can be used with that proximate causation to prove negligence. If you are taken to court and held negligent, you may be required to pay the damages. Most of the time, the departments you work for are going to carry some sort of malpractice insurance, so it may not come directly out of your pocket, but it potentially could, depending on the situation, depending on the severity of it, depending on what exactly you did at fault, and if you knew better. It can, in essence, fall back on you personally at that point. Now, if there's a lawsuit against you, there is the possibility that it could be criminal, depending on what you do. You're seeing a lot of that right now on the police department side, where they're doing things and they're being held criminally responsible, just given the nature of, everything that's going on in the world right now. More times than not, a lawsuit against an EMT is going to be classified as a tort, which is more or less just a civil suit against you, where they're coming after you. Personally, you're not going to go to jail for it, but you could be held financially responsible for it. And then basically the concept with this is basically saying the thing speaks for itself, so they can make an assumption one way or the other given the certain situation. So back to that stretcher dropping, the patient had zero control over it. So it's assumed that you had full control over that stretcher. So if the stretcher drops, regardless of why, it ultimately is going to be your fault. Whether it's mechanical failure because you didn't check equipment or because it's human failure, ultimately it's going to be your fault with that. Really, the biggest area that you're going to see lawsuits against EMS personnel fall back to the refusals, which we covered in great depth earlier, so I'm not going to just beat my head against the wall with that. You need to understand the refusal component. And then the other one is ambulance collisions. And as an EMT basic, if you go work at a paid service, you are going to spend a tremendous amount of time driving the ambulance. You're going to spend a tremendous amount of time driving the ambulance with patients in the back, and that is a whole different responsibility. Because now if you get into an accident and it's your fault, you can be held responsible, you could be held negligent, depending on the situation. So we're not trying to scare anybody off with this chapter, but there are plenty of legal concepts that you need to understand as an EMS provider. Duty to act. So we mentioned it a couple slides ago. Now we'll talk about it a little bit more in depth. But it is your obligation to provide care to the patient. And it's not a black and white situation as an EMS provider. There's going to be many shades of gray here that you're going to be put into the situation of. And basically, if you're on duty and you get called, you have a duty to act. So we're a volunteer service. If you're on call, you have a duty to respond when that pager goes off. If you work for a paid service, you have a duty to respond when that pager goes off. If you ignore it, you can be held liable. And we've already talked about that in great depth. Where it becomes gray is when you're off duty. Or you're on duty, but you're out of your jurisdiction. The bigger gray area is when you're off duty. Say you're driving out of town, car accident happens in front of you, what do? And basically there are going to be laws that protect you as long as you're acting in good faith and you're working within the confines of what you can do. A lot of times you shouldn't carry equipment with you more than what you can buy over the counter. So you shouldn't carry a C-collar. That's an actual medical treatment. And at least in Illinois, there are certain steps that you have to go through to carry that equipment. But, you can carry bandaging, you can carry tourniquets, you can carry, any of those things, Narcan, you can carry any of that stuff that you can get over the counter, you could have on you. And if you try to help a patient and you're doing it in good faith, with good moral judgment and, within what you've learned, usually you can't be held legally liable for an outcome. Now, if you work outside of your confines, if you freelance and do things that you're not trained to do, that's a whole different situation that you can be held liable. Now, let's say you're on duty, you drive 40 minutes to a hospital, you're on your way back, and that car accident happens while you're in the ambulance. Now, a little bit different situation because you are in an ambulance, you are on duty. You may not have the duty to act because it's not your district, but you should do what's in the best interest of the patient. I will say this every single time through the entire class. When in doubt, call medical control, give them a quick update, say, hey, this is what's going on, what should I do? Lean on them, let them make the ultimate decision. And some of this may vary from state to state. So you need to understand your protocols and what, if you're working in Illinois, what the state standards are, so that you don't get yourself in more trouble. At the end of the day, follow your conscience. I've had it both ways when I've been off duty. I've walked right past things because I didn't want to deal with it, and I'm sure you've all heard people make the joke, it's not me, I'm off duty. and I've done that. Everybody's done that. But if you can maybe change the outcome, use your moral judgment, follow your conscience, and everything will turn out okay for you. And the second thing with duty to act here is abandonment. So that is basically exactly how it sounds. You leave the patient when you shouldn't have left the patient. So once you initiate care, it may not be discontinued until you transfer it to the appropriate medical personnel of equal or greater training. So if you are an advanced level provider, this is where kind of that duty to act becomes really gray, and you're probably going to have to get medical control. And you're coming back from the hospital, you come across an accident, you initiate care, the service whose district you're in shows up, and they're a basic service. Now, you can't technically hand off care to a lower level provider. So I would get medical control involved in that specific situation. But if you're a paramedic, you have to hand it off to a paramedic or higher. If you're a basic, you have to hand it off to a basic. You could transfer care to a paramedic. So if you're a basic ambulance coming back from the hospital, you witness that accident, you start care, and a paramedic shows up, you can hand that patient care off, and then you can leave and continue back to your town. There's just so many different circumstances when it comes to duty of act that it's gray, and utilize medical control. If you fail in this, it could be considered abandonment. Another area that you need to use caution with is you get called to a car accident with 5 patients, and you're the first ambulance there, and it's going to be 6 or 7 minutes till the next ambulance is there. You can't just load up one person and leave the rest, because now you have, in essence, abandoned the rest of the patients. So you need to triage, initiate care, do everything you can until other ambulances get there, and then you can load up a patient and leave as long as there's another ambulance there, or maybe you start handing off patients to ambulances as they come in. Very late in the book, we'll talk about the mass casualty scenarios, but just because you have a patient that you need to get to the hospital, if there's other patients, that's also another gray area. Utilize medical control and kind of determine your course of action from there. And then just to kind of finish here on these Good Samaritan laws, I mentioned them earlier, but basically, if you're acting in good faith, you're working within the confines of what you know, you're going to have immunity from being liable from a situation when you don't have that duty to act. It may not cover all situations, but the vast majority of situations, the Good Samaritan laws are going to cover you. When you stop at that car accident, or you're in the restaurant and somebody has a choking episode, or you're at the airport and somebody collapses and needs CPR. They're real life experiences. Do what you can for the patient. Use your morals, be ethical, and just do the best that you can. They're not going to protect you from gross negligence or violations of law, obviously. So if you work outside of what your training is, or do things that you shouldn't do, then you could be held liable. That's where the common sense of knowing your scope of practice, knowing what you can and can't do, will really come into play. And then just kind of putting it all together here, we talked about both of these in depth. So the patient is in cardiac arrest, the family says they have a DNR, but they can't find it. What do you do? By the law, you need to start CPR until they can come up with a DNR. But also utilize medical control. They may allow CPR to be discontinued. Just really take that responsibility out of your hands, and either they come up with the paperwork or you pass the buck on to the next level up. Second scenario here is that vehicle crash. Police and EMS haven't arrived. Are you legally obligated to stop and render aid? Legally, you're not obligated. Morally, you may feel the need to stop and render aid. Just really depends on the situation, and use your best judgment whenever you're put in that situation. It will happen. I guarantee you, over the course of time, you will have a number of these situations come up. Just follow what your gut says, do what you can, work within the confines of what you know, and that's really all that you can do. Moving into confidentiality now, and it's just a couple slides here. This is its own real in-depth topic, and actually one of the modules. For week 2 of the class is the HIPAA module, which will be attorneys talking in great depth about confidentiality and some of the rules and regs that apply to it. But for the purposes of this chapter, understand that you will be divulged to some sensitive information on the patient, whether it's their medical history, medical conditions, how you treat them. You might be seeing some of their personal information as far as social security number, address, insurance information, things like that. Know that you have a duty to keep that information confidential. It is a very easy way to lose your license. I've seen more than one person lose their license for a breach of HIPAA. It's not something to mess around with. It can get you civilly sued. It can get you in legal trouble. It can get you in trouble with the state where you lose your license. So just understand confidentiality and the importance of it in the world of EMS. And then, like I talked about, the actual rule, it's called HIPAA. It's the Privacy Rule, the Health Insurance Portability and Accountability Act. Any place you work, you're going to have to go through HIPAA training. We do it annually with our department. Sometimes they do it more frequently than that. You're going to basically go through the same training that we put all of our people through every year in that HIPAA module. Know that there are times that you can share that information. You can share it with other healthcare personnel. You can share it with the registrars that come and get the patient information to admit them into the ER. If it's properly requested and it's signed off on by the patient, you can share it. A lot of times that's in lawsuits. We'll get phone calls for charts, and then there's a paperwork process where the patient has to actually sign off on that information being given out to somebody else. Otherwise, it really needs to be obtained through a formal subpoena. Beyond that, you don't share information. You shouldn't even go home and talk to your spouse or significant other and give details. There's a way to discuss things and a way not to discuss things, and it's basically when you share things that could identify the patient, then it becomes a confidentiality issue. If you're just sharing the what ifs of the call, not so much unless it gives away who was in that call. Lots of gray areas with this as well, but pay attention in great depth to that HIPAA module. It's dry, it's by attorneys, but it is very important. Something else to look for, especially when you go on those patients that might be unconscious or not able to give you information, is look for indicators that could maybe point you in the direction of what's going on. It's pretty common for diabetic patients, seizure patients, that they'll have some sort of medical alert. Commonly, it's a bracelet or a necklace that you can look for, but there's a number of different ways that they put that information out there. We'll cover a couple more on the next slide. But just pay attention to that. Another place to look is always, a lot of times, especially in the elderly, they'll keep the information on what's called a file of life. We always train people, put it on their refrigerator, because that is a good place that universally you can go look at, see if there's some paperwork there that might clue you into the patient's past medical history, clue you into what the problem could be that you're looking at that time. And then, like we said, necklace, bracelet, card. Your book uses the picture, somebody tattooed diabetic on their wrist. Really, there's just any number of ways that information can get to you. Hopefully it spells out a specific medical condition. Like I said, diabetes, seizures are really the two common ones because those are ones where you might find the patient unconscious and, not have any clue of what direction you're going. But if you can find that indicator, then it is going to make your job just that much easier. But it's not limited to those. It could be a patient with allergies, patient with heart conditions, could be a patient with a stroke history. It could be any number of things. Just again, it's a way to look for resources to help you in the assessment process. Another special situation here is with organ donors, and it's a great thing for people that are organ donors. I've transported a number of patients that had organs donated. Kind of the important thing to know is, even if you know the patient's not going to survive, do everything you can to sustain that body and those organs. So make sure you're doing good quality CPR, you're giving good oxygen, because as long as you're pumping that blood through the body and as long as you're oxygenating that blood, you're going to give that donor the best possible chance to be able to get into the OR, have them pull viable organs to get those transplanted into other people. The most common place to look would be on their driver's license card, but family may discuss it with you as well. It's something you'll want to definitely talk to the hospital about, nursing staff, when you get there, that, hey, this person is an organ donor, and just kind of go from there. Like I said, usually you're not going to save the patient, but you may save 2, 3, 4, 5, 6 other people by doing your part, preserving those organs, getting them to the hospital in a timely manner, so that they're still viable to be used in somebody else. And the last little special situation here, safe haven laws. Basically, any hospital, fire station, police department can be considered a safe haven where a person is allowed to drop off an infant or a small child for any reason, without question, without being held responsible for them. It can be difficult in volunteer places where they might not be manned. But just know that if you're put in that situation, wherever you're at, that you're going to contact the social services. I would probably contact your medical control. Make sure that there's no questions on that end. But you want to make sure to get a hold of the social services then and kind of get that whole ball rolling. And then it's basically going to be passing on a lot of information. You're going to want to take care of those children, bring them into a warm, clean environment until they can be handed off to the proper authorities. Okay, moving on to crime scenes, and this can be a complex situation as well, because you might be put into scenarios where you arrive on scene, and you actually might go into the scene before police gets there, depending on the situation. Obviously, your scene safety, your personal safety has to come first. But if it's just a run-of-the-mill medical call, you may beat PD there, and you may go in and find a patient that's deceased, that there's nothing you're going to do. Most areas in law enforcement, when it's an unattended death, they're going to treat it as a crime scene until they have a chance to investigate and verify that there's nothing questionable. So what to do is know that everything there is evidence. So anything you move, you need to make a note of in case police have questions. Anything you touch, you need to make a note of in case police have questions. Take proper steps to preserve the evidence, and just understand that you can completely mess up a crime scene by what you do. So if it's an obvious death, the fewer people in the scene, the better. So it might just be one person from your crew going in to confirm it. But if it's something else, if it's a stabbing, there's certain things that you need to do to kind of preserve some of that evidence. So they don't want you cutting a shirt right through where the stabbing hole is or the bullet hole is or anything like that. You need to cut around it so that they have that preserved evidence that they can use in the future. Basically, treat your patient, but when you have the ability to use law enforcement's guidance for what their needs are when it comes to the actual crime scene. And this is just a few examples of evidence, like the condition of the scene, and these are things that you might want to include in your chart. So if the residence is, completely tore apart, you might want to make some notes. If there are empty pill bottles near where the patient was, you're going to want to make a note of that, so you include it in your chart. You're going to want to make sure to include in your chart really good detailed description of your assessment of the patient. If you kind of assume that it's going to be a crime scene, but then there are things that you can add to or mess up in fingerprints, footprints, etc. I know of a shooting that happened years and years ago, and there was like 5 or 6 EMS people that went down there before PD got there. The scene, it was secured because the people had left, and all that. The only thing that was left there was the body and an adult from the house. But it completely messed up the crime scene because there were now 6 new sets of footprints through the whole area. So you have to use good judgment, use some common sense when entering a scene, when exiting a scene. Just make good notes of everything that you see. And finally, and just really continued, preserve the evidence. Remember what you touch. Tell the police what you touch, what you moved, what you've done. If you don't need to touch something, don't touch it. If you don't need to move something, don't move it. Really just use common sense when it comes to that, and try to minimize the impact that you have on the scene. Work with the police, talk to the police. If you have the ability of taking law enforcement in with you when you go in, do that, because then they can kind of point you in the right direction as to, hey, I need you to step here, or I need you to do this, or I need you to do that. This falls back to that chapter 1 where you're working hand in hand with other agencies, and you need to be cooperative with them and work together. From a special reporting requirement, I'm just going to touch real quickly on this because it varies from state to state and region to region. It's pretty universal in most states that you're a mandatory reporter for child abuse, for elderly abuse, for domestic abuse. But depending on where you are, you may have specific reporting requirements when it comes to human trafficking, violent sexual assaults, situations where you have to restrain a patient. There may be some special reporting that you have to do. Even things like animal bites require some reporting to the county usually. So that's something you just need to learn for your specific area, but understand that there is special reporting requirements. And then, just a few more examples here as far as intoxicated persons with injuries. Really depends on the scenario. You can't, if you have a car accident and the patient tells you that they've been drinking, you can't run out and tell the cop that they've been drinking so that they get a DUI. There's still some confidentiality, but understand the laws and the protocols for your region, because there may be certain things that you do have to report depending on the situation. And then kind of final topic of the chapter is other ethical responsibilities. And we talked in great depth about this in chapter 1, in the introduction to EMS. And understand the morals and the ethics of your job. Understand that your personal opinion may be right and may be wrong. It's not your job to pass judgment. It's your job to take care of the patient. So no matter what your opinion is, you've got to look beyond that and treat each person the same way no matter what. Understand the standard of behavior for your profession, and then be ethical as an EMT. Be honest in your reporting. Don't skew what you report to make somebody look bad because you have personal judgment against them. That may fall back on you, and you could get in some legal trouble then. So you need to be honest in your reporting and document what you did and what you didn't do. If you were supposed to do something and you didn't do it, don't put in there that you did it. You're going to be a lot better off just documenting the actual facts of what happened on the call. Remember, you're there to work to help the patient. And then finally, respect the right of your adult patients. Doesn't matter what the situation is. Don't treat them like a baby. Don't, speak down to them because of something. You don't know what they're going through. You don't know all the circumstances. You don't want to pass judgment and basically make somebody guilty when they're not. Everybody's innocent until proven guilty. So just understand, your job is to take care of the patient. Treat them fair, treat them just, take care of the patient, and treat them with that standard of care no matter who they are, no matter what they've done, no matter what the situation is. If you do see coworkers or others not really following by these expectations, then you need to utilize your internal chain of command so that you can report that misconduct and get it taken care of, because everybody deserves to be treated fair. Everybody deserves to be treated ethical. At the end of the day, we just need to take care of the patient and do your job. And like I said, just do your job. That's what is expected of you. That does it for Chapter 4. Chapter 5, not sure if I'm doing or Marcy's doing that. One of us will have that one done here shortly, though, so that Unit 2 can be up there. Like I said before, I'm not going to read the chapter review to you. Go through it, use it as a study guide. Understand that if they put it in the review, it's pertinent enough that they feel like they should have put it there. It's also probably pertinent enough that they might ask some quiz or test questions on it. Move forward with the review. If you guys have any questions or anything on the chapter, make sure to let me know, and we'll get them answered for you. Otherwise, good luck on the Unit 2 quiz. You got one more chapter to go as far as listening to the lecture, and then you'd be set through Unit 2.